So my name is Schmertmann. I'm a medical social worker at the Comprehensive Neuromuscular Center at Cincinnati Children's. I've been working there going on about 4 years. Something about my role in there too is I have the luxury of being able to dedicate a lot of my time to neuromuscular care and also just attention. So resources and everything that is what drives me to go to work, just getting value to you somehow. And that's really one of my goals here too. And I'm already getting ahead of myself because my goals are next. But I have a BA in philosophy and that'll come up later. I apologize. And I also have a master's in social work that I got from Florida State University. And I'm originally from Tallahassee, Florida. And so my journey to social work and also the medical field started at a medical summer camp. It was really off the cuff. I just wanted to volunteer, somebody pointed me in the direction, and it was just an incredible experience. That led to going into social work, where I had a clinical experience at All Children's Hospital in St. Petersburg, Florida, and worked in their hemophilia treatment center. So got to experience that kind of chronic care model, and I realized that it was something that grabbed me. I already said that. So no disclosures, nobody's paying me. If you know anybody, let me know. And so to preface this, I kind of just want to take you on my thinking when I was writing this, because it went through a few stages of changes. Because my original plan was kind of map out like a patient journey and then show how siblings could be considered kind of parallel alongside, because I think there are a lot of parallels where if you're thinking about your affected loved one, then just kind of extend that over to the sibling a little bit. But I realized that I was kind of imagining situations and I wasn't completely comfortable with that because it is just such a very real thing. And also I had the opportunity of meeting with some siblings from PPMD's SibConnect group. So I got to talk to them one-on-one and they just shared their insight. And so I realized that a better use of my time, a better use of your time and my role is to essentially just amplify their voices on this platform, but then also kind of give you my professional input and kind of my take on it. And it's also my hope that you're gonna take something away from it. And also I want to note that I am not at any point trying to indicate that you are doing something wrong or you have done something wrong. That's not even the kind of question we're talking about. It's not a wrong versus right. There's no fault involved. It just is a situation. And so my goals are exactly like I said, share those stories from patients. I also have one family story that I thought was particularly relevant. And then I'll add notes from a social work perspective. And my goal is to provoke your thought. And so onto those points. And I'm going to be highlighting the themes. And so I'm going to try my best to kind of say like what is from me. But otherwise, this is direct input from patients and siblings and families. So we're going to start with a palliative story. And the situation is palliative care is part of our neuromuscular team at Children's. It's just a fully integrated part of our care. We don't really transfer adults to other institutions. There are some caveats to that, but for the most part, we keep them. So we see adult patients, and part of adult care is including palliative care, just for anybody, whether you're affected, unaffected. Palliative care is just not hospice. That's what I really want to emphasize, and that's what I really do in my role as kind of the bridge from the family to the palliative team when we integrate them, because palliative care is not hospice or end-of-life care. Hospice is a part of palliative care, but palliative care does not mean hospice. So when we're bringing them in, it's really just part of normal care, being proactive and kind of establishing lines of communication in case future conversations are needed. And so in this case, it was an older patient and parents had formal guardianship. As you might have learned from last session, that means that his rights as an adult were legally removed and kind of transferred over to his parents. So they were full decision makers. So that led to them having questions about legal forms, which is natural. What do advance directives look like? So then they thought, well, our other kid is a lawyer, so we'll ask them. And so they asked him about advance directives, and that just ended up kind of being an exposure that they weren't expecting to be too much for the sibling. Turned out they kind of had some some turmoil in their own life and it hit at a time. And also they didn't have context for what palliative care meant. They didn't have the benefit of my kind of disclosure, decoupling of palliative from hospice. And so their mind just went racing and had no idea what was wrong with their brother and, filled in the blanks with their imagination. And so what that led to was a dual relationship. And that is actually something that is a professional term. Pretty much just means when somebody's filling two different roles and those roles are competing. So when we're going through school for social work or just any kind of counseling, common example is you can't really be a therapist to somebody that you're also a friend to. Stands to reason because a therapist's job is to be objective, offer assessment, and you just can't do that. And I'm sorry, not great at matching this up just yet. But yeah, so you see those two really just those two roles just kind of came to a head and in a way that they weren't expecting. And so the point that the siblings made to me was about balance and just kind of balancing their involvement and awareness in terms of how exposed or underexposed they are to care. And so kind of the two extremes are being overinvolved or overlooked. I'm going to start on the left, and overinvolved, that top one I think is my favorite. I could probably do a whole presentation on that, but it unknowingly kind of strips them of their own autonomy. And by autonomy, I mean kind of their allowance to create their own sense of identity, and in particular, their own distinct identity. Something that was shared with me was, they might feel pressure to turn down social events like sleepovers or parties because they're thinking about either their care needs, they're thinking about the exclusion of their sibling. So that can kind of lead to them turning down age-appropriate opportunities that could be really good for other connections due to care reasons. And yeah, it's a balance. And so they said that they really just kind of wanted to say in what their involvement looks like. And they'll likely have thoughts too. They're constantly thinking, they're constantly feeling, and so they probably have a lot to share and talk about. So really it's kind of a question of teasing that out. And so they want to also be able to talk to a parent and not a manager. And that is kind of a dual relationship that I know you guys probably find yourself in sometimes, and it can be tricky to navigate. And so a particular thing too was one of the siblings shared that he was really anxious about if college away from his home would even be allowed, and also kind of wondered if they could handle it. Like that was just kind of a filter that they had to run through just in order for kind of a normal experience of thinking about college. And then also different siblings, not even that one. One sibling shared that he moved back home by choice. He kind of went off to college, realized he couldn't really handle it, wanted to be closer, so he moved back, and it was fine. And then another sibling shared that they went off to study and absolutely loved it. They found that they were thriving, and they actually even kind of turned their studies into a medical focus, and I think they're in some kind of advocacy position now for medical needs. And so what it does, as I said, with the dual relationships is it just blurs boundaries. And especially with caregiving help, just because there's that sense of, am I an employee? Am I a sibling? Like, what's my role here? But in particular, what's my emotional role here? Or, what directions are my emotions being pulled with this? And they said that it's one thing to help here and there, but it's kind of another thing to be used or leaned on as an ongoing support. So, I mean, it's really tough even for me to grapple, just like the pressure of being used as a resource by your parents for your sibling. Not that it's inappropriate to ask, because people like helping other people and they like being involved, but it really is just, it's always going to go back to balance. And so they also said that if it's true, and I do say like if it's true because situations differ, try to highlight that the sibling is not a necessary part or like a required part of the patient's care. If it's not fully true, also, that probably means that you could use some help. And so I would recommend finding a social worker or somebody in the community, Cure CMD, Team Titan, whoever, to help you find that support. Because if you're leaning on one single person to be able to provide good care, then it's probably a sign that you could use some help, and help is out there, even if it's frustrating to connect to. And when it comes to being overlooked, kind of alluded to this earlier, but it just leaves them guessing. And it's also, we talk about this, and this is one of those parallels about kind of disclosing the diagnosis to your loved one and to the affected loved one, just kind of what that means. And if you don't tell them anything, and them here now is the sibling, if you don't tell the sibling anything, they're also going to be left guessing about what is happening to my brother, what's happening to my sister. And childhood imaginations are really cool, but they can lead to some really scary places that you would never think about with an adult mind. And so it's really important to kind of touch base and just clarify, even if it's just a little bit of kind of a tonal push of like, things are fine, because it's yeah, it's just an easier conversation to have, to explain your siblings, your brother, your sister's body works a little bit different than all of the things that they can imagine. So the chance is that the truth with your context and with your support is going to be a lot less scary than whatever they can concoct in their own head. My childhood dreams were wild, yours probably were too. That's what they're thinking. And a point from them for parents and also clinicians, because I wasn't exempt from consideration either, is to attach the sibling education to the patient's education. So for clinicians, they challenged me, if I'm trying to teach or counsel the patient on something, just kind of run that through the lens of, what's the sibling thinking? Is that something that I should acknowledge? Should they be included? Just kind of like think about it. Really just leading to questions. So to summarize this part, preventing them from being involved is pretty much impossible. They have access to Google too. So you're not really going to keep anything hidden from them. You're just going to not have them have any context for what's going on. And also, when we talk about emotions and just trying to guess at what people are thinking, there can be a certain sense of kind of a lack of control because you just don't know where it's going to go. But what their involvement looks like is something that's in your control. And it's the kind of thing where if you don't do anything, then that is doing something, because then you're emitting everything. And so their suggestion for parents was pretty simple, and I loved it. Just check in and try to make sure that you're setting the tone that you're available for them if they need you. Just be an open point of questions. Again, add context. I go back to the word context a lot. And sometimes just being available is enough, and that's all you need to do. And so a sibling suggestion to kind of curb that is try to remember their real age, not the age they seem. Because a big theme that I see when I'm talking to somebody about, I don't know, what they want to do for college, and they're super driven, and then I take a step back and it's like, oh, you're 12? That's thinking pretty far ahead. I kind of was taking them on as a 17-year-old, but that's not where they're at developmentally. And that is part of why the balance can kind of tip or sort of drift without you being aware of it. Because just like affected community members, siblings are naturally pushed to mature faster, and that is special, but it's not without risk. Because going back, it can make them kind of neglect age-appropriate needs, can kind of be difficult to accept normally age-appropriate behavior. And there's also just a certain amount of stress in being asked to do things that are just beyond your developmental level. Taking on more adult or mature considerations, but with the emotional tools that are below the level required to pick them apart. And there is such thing as telling them too much information too, because yeah, it might seem like they can really handle some of the more difficult things because they present as so mature, but a 13-year-old is going to handle a difficult conversation or the conversation is going to need to look different from your end for a 13-year-old, simpler language, fewer details than it would with an 18-year-old, where you can kind of get a little bit more on their level, not as a peer, but at least the maturity levels are starting to kind of get to the same level. And it can also lead to, and this is sort of again, this is not any kind of a judgment or anything. That's my own anxiety speaking, but using them for emotional support should be a red flag, because that really goes back to, as well, that dual relationship of a professional and a friend for being a therapist. But it's even more enmeshed because there's patient, sibling, therapist, and it's just really tough to kind of figure out what your role is in that. Because it's really, I kind of think about it with transferring the stress and the energy and kind of what that flow looks like, because a sibling parent relationship should be the sibling stress, the siblings, or in this case, it's child parent. Child stress should go to the parent and not really the other way around, because you're going to be able to take that pressure that they have and kind of like dissolve it into the air, because you can just handle things a little bit better. So other points that I wanted to share from them, these were a little less thematic, but just no less important, is time is a resource that they also need. Parent attention is precious to kids, and you're not going to have, it's a resource you have to divvy up, because care demands time, but they demand time as well. And carving out non-CMD time can be important too, because if care dominates the time of family interactions, that can kind of make it feel a little bit more clinical rather than part of a family. And so checking in, giving them space to talk about things, especially because feeling guilty is common. And so it's really just giving parenting time and normalizing open dialogue, and doing that early can also help kind of make future conversations that are difficult just a little bit easier, because a check-in is just a natural part of your process. It's a natural part of your rapport. And guilt is something that I think is very profound in siblings, and it's really tough to take on, because as a social worker, I try to take on the viewpoint and exercise empathy. And this is just a time where I feel like my limits in that are really evident, because there are just so many factors going on there. And whenever that comes to me too, I always think asking is best. A direct report is good when you can't really accurately guess. Yeah, and so just more check-ins, because guilt is really difficult to guess at. And just making sure that that any guilt they have is definitely not a point of failure on your end. It's a natural part of their relationship. Again, it's not good, bad. You're not working with that kind of gradient of good, evil, good, or anything like that. It's not qualitative, it just is. And so just their guilt comes from a place of consideration and love, but it should still be addressed. But yeah, and also for clinicians, just acknowledging that siblings exist, especially if they're in the room, goes a really long way. So just at the end, do you have questions? Do you have questions? Do you have questions? And then extend that to the sibling, and also try to remember their name. And if they're not there and you know that they exist, just try to drop their name in conversation, just acknowledgement. So now I have some tips just as a social worker. And one of my favorite things to work with and think of, because I think it's a really easy take home for you guys, is mindsets. And that's just kind of ways to organize your thinking when those thoughts are scattered, because it's really tough to kind of lock those in if they're just, I don't know, my mind's going to herding cats right now. And so if you're in doubt, just start with what you know. And in this sense, it's more, what are the extremes of what I know is incorrect and what I know is incorrect, but on the other end, going back to that overinvolved or overlooked. And so nice little line there. So that would look like they're crucial for care. That would be one extreme that you want to avoid. And so what are the steps working back from there, where it's like, that's where you can't take any more steps back to the middle to exclude them? Like, what is their absolute necessary point of needing to be involved. And then, next questions from there are just dependent on where that answer is. Then the other end is people asking, oh, I didn't know you had any other kids, when they see you out and about with your whole family, because siblings being overlooked, the affected individual is kind of being the focal point of most interactions. That's what you talk about with friends. It can just happen. And also create a goal, because I set goals with young adults all the time. It's one of my favorite things. It just adds an easy end point, and then you kind of fill in the blanks from there. So, and also I say it's a goal because it's not something that's easy to accomplish, and it might not be feasible. So it's kind of a heading, but not necessarily a task that you have to accomplish. And so, only ask for help so many times in a week, and then track that. If you're a little bit off the mark, if you're asking for more help, just think about why. And then maybe on Saturdays, I'm just not going to ask for their help with care. And if you're able to do that, that might be revealing and just kind of lead to other thoughts. So these really are starting points for you to kind of interject your own context into these. It's supposed to be kind of a model for you to take and just kind of consider, just for your brain to kind of run through these practices. And so some other social work points of note: missteps are okay. When it comes to messing up, it's really easy to say you're sorry, especially when we're talking about siblings. There's kind of a natural point of love. If it's a younger kid, in my experience, kids always start from acceptance and forgiveness, and then they either work backwards or just kind of hang out there, enjoy the view because they have beautiful minds. And check on who you're protecting. And by check on, I mean, again, just kind of a mental analysis of your own thoughts and behaviors in the moment. Because if you're excluding them, it might be because of protection, which I would argue is a good thing, but it might be avoidance and more for you. And that is, again, a natural human thing. It's not fun to be in uncomfortable situations. It's easier to not talk about things than it is to talk about them, especially when they're hard. But the trick is it your discomfort that's kind of leading to the exclusion, or is it their discomfort that would happen at an inappropriate level that you're maybe saving to engage when they can take it on more? I would say that's more protecting and a little bit less avoiding, because you can include them with context and support, and that can be protective too. Protection doesn't mean exclusion. Protecting them can also be including information or bringing them into the loop, but in the right way, because then that avoids and protects them from their own imagination and their own gears spinning. And again, that'll just look different for you and your family. And I cannot stress enough, check in if you're worried. Super easy to ask how somebody is feeling. If they're a teenager, they might not be so forthcoming, but chipping away at it. And again, if you start early with just establishing this process of checking in every now and again about what their experience is like, later on in those difficult teen years, they might be a little bit more accommodating just because it's something that they're used to and they already understand why. So yeah, check in. And boundaries really are crucial. I definitely want to take some time on that, because most of the boundaries really are the same as if their sibling was unaffected when it comes to the parent-child relationship. And as is often the experience in the disability community, a lot of things are possible. A lot of things are kind of look like they do for able-bodied people, or a lot of the possibilities are the same. They just look different. Driving, you can drive. It's just adapted. It looks a little different, and that's fine. And professional validation too. I want to point out that in the Diagnostic Statistic Manual, I think we're on the 5th edition now, it recognizes secondary trauma under the PTSD diagnosis. And so on a very formal academic level, a group of psychologists agreed that being exposed to trauma or just difficult emotions, even secondhand, can have an effect on somebody else just as a passerby, as a bystander, as an observer. So if you have an emotional stake in someone else, their hurt can become your hurt. is kind of what I think that boils down to. And then another kind of tool that I want to offer is this 2-question self-check, because ultimately siblings just value having a choice in shaping their relationship to their siblings' care, and just kind of them setting the terms of what that means to them, or at least being included in the conversation. And so, do I know what X here is the name of whatever sibling you have in mind? So do I know what they're feeling or thinking about this? And then it's just yes or no. If yes, then that's great. Next steps might lead from there. If no, then the next question, should they? Because the answer could be yes, could be no, could be revealing. And I never like ending a presentation without sharing some actual supports. There are sibling groups out there for support. Sibs Connect from PPMD is one that recently formed. They're even doing sibling track conference programming, so could be something to think about here too. That was grassroots from them, so that's kind of another example of checking in. I wouldn't assign programming duties on them unless they're interested. And if anybody's watching virtually, there's a print screen PRT-SC button up at the top row. If you click that and then paste it into a Paint document, that's a screenshot. So I'm going to give it about 5 seconds to see if people can work that if they need to. And that's all I have for now.